from the processing cell of the side stem in the side branch. So final kissing balloon inflation and final port. So finally, this is my last slide to show the take-home message. So in general, of all bifurcation lesions, more than 70% are classified by simple bifurcation lesion, which could be successfully treated by proximal stenting technique. DK quality is associated with low rate of tight lesion failure at 1 to 5 years of follow-up, particularly for complex bifurcation lesion or distal left main true coronary bifurcation lesion. I think definite criteria user-friendly to identify a complex bifurcation lesion have been confirmed by meta-analysis, consecutive study, and randomized study too. Finally, I think intravascular imaging are very important to guide the stenting technique and device selection.
Thank you so much, Professor Chen. It's always been a pleasure to have you for the lives as well as talks, and you have been such a great for Pakistan Live and Pakistan Society of Interventional Cardiology, on all the course directors as well as scientific committee and so Interventional Cardiology Council members. I really want to thank you for everything you have done, you've been doing so far for Pakistan in terms of education, teaching and participating in our meetings. Thanks a lot.
Sir, quick question to Professor
Thank
Chen.
you, thank you.
We have
Professor Chen.
They are ready for the case. Yeah, I think they are ready. Professor Wu is ready for the case, so go ahead and put them on. Thank you very much.
Thank you.
I'll hand over to Professor Zubair Akram to moderate the next session, please. Thank you.
Mr. Rahman, and may I request Professor Khan Shahzaman to be on the stage. He was among the panel of experts for this session. Thank you very much, Dr. Bashir Hanif. I'll be moderating the next half of the session. To start with, we'll be going live to China, to Fu Wei Hospital for Professor Yang Jian Wu, who will be performing a case most probably on a bifurcation. So can we go to China?
Yeah, actually, according to Professor Chen's suggestion, Professor Chen put 2 stents from the ostium left main to the proximal ID. One is 3.5 by 23, another is 3.0 by 23, overlap at the proximal ID. Then we do the post dilation and the port. For left main, use 4.5 balloon to do the port. And considering there is a huge aneurysm in the distal left main, and also the aneurysm diameter is 7 millimeter. So after port with the 4.5 balloon, we do the final kissing. We rewire the circumflex. And with the 2 3.5 balloon in LAD and the circumflex, and do final kissing. You can see, can you see the angiogram?
Yeah, we can see. We can see.
This is first try to access the circumflex, but from the angiogram, actually it's from the proximal cell. Next, then we secondary rewire the cinch, and from the angio, it's from the middle cell. Then we do the final balloon inflation with the 2 3.5 balloon. Next.
So these are 2 4.5 balloons?
3.5 balloon.
Okay, 3.5.
Yeah, this is the final kissing. Yeah.
Okay.
We finish with port. Finally we use the 4.5 balloon to do the port and complete the case.
Okay. Did you do IVUS after all this? Yep.
Yeah, sure. We do that. Can I show you the IVUS?
So what about the apposition now?
Dr. Panto, can you introduce the IVUS?
This is the IVUS proximal LAD to the left main. This is the POC. This is the circumflex wire. This is the distal left main.
Yep. So it's better.
Yeah. The osteopathy area is 10.9 square millimeter, and this left main area is 13.1 square millimeter.
Okay.
And we can see here, this is the crystal is in middle. That's all.
Okay. Just show the left main views and before.
Okay, this is the final picture of left man standing after left man standing procedure.
Okay, thank you very much, and we leave you there. Thank you very much for a wonderful case. Now I'll move on to.
Thank you. Thank you.
Thank you very much. Now I move on to Rosalie Muhammad Ali for his talk on provisional stenting and TAP. Beautiful simplicity. I must first of all, as a moderator, thank Dr. Rosalie for his ever-ending support to Pakistan Live. So we are so proud of you, Dr. Rosalie. So over to you for your presentation, provisional stenting and TAP, beautiful in its simplicity.
Thank you for the invitation, and it's been good to always be with you. So Shaolan has actually showed you all the data. I just want to show you and share with you how provisional stenting and TAP is beautiful in simplicity by sharing with you some cases, or rather two cases. This is a 60-year-old man and functional class 2, CCS2, with Medina 1 in the LED and diagonal. And I thought the diagonal was short lesion, even though it's a true bifurcation, and I just wanted to have a stent crossover. So this is after pre-dilatation. You can see the stent across the diagonal, and once we have deployed the stent, the flow is fairly short, fairly slow, and these are the cases that tend to use a kissing balloon technique. Now, this is actually a jail balloon technique, but that is not the aim of my presentation, but just to show the final results after killing. So we ended with pot. After potting, we have kissing, and that's the final results. So the results are TME3 flow, and since still side branch, we decided not to put a stent in for the side branch. So essentially, if I were to use a one-stent strategy, and it's been noted that the majority of cases tend to get away with a one-stent strategy, it's a fairly simple, straightforward, only for the risks of stent thrombosis, especially a side branch stent low. But what is required is that once you put a one-stent strategy, you should have a minimal requirement of pot, the proximal stent. There was a question about kissing inflation, but this is in most cases not. But if you intend to kiss, especially when the flow is slow, and when you find branch is pinched, and usually it's more than 70% stenosis of stenting, then you should try to ensure in the short non-compliant balloon in the side branch. So that's strategy. But if you have to have a two-stent strategy, that was defined by Dr. Chen Chong, especially in the left main stem, then go ahead and do a two-stent strategy. Various number of two-stent strategy, but I've been asked to show what is. So this is a 43-year-old man with unstable angina. And yes, in Malaysia, the young patients, just as you do in Pakistan. So if you see this bifurcation, and now the lesion in the side branch, in this case the circumflex, is 10 mm. And true, this is a two-stent technique is required in this case. So after this another lesion, there was also another lesion in where septal branch was, but it didn't show. It's probably eccentric and I did it behind, and not to stent it. So that was the initial, initial objective or aim. So with this, with the scoring balloon to the circumflex and also to the LED, that was the results after scoring balloon dilatation. We then took a stent, and in this case, I wanted to do it with the stent from the left main stem into the circumflex first. So 3.5 at 28, and this was deployed at 14 atmospheres. Then we took port 5.0. This was IVERS guided, and this was about 12 atmospheres. And once after that, 3.5 non-compliant balloon and went at 20 atmospheres to the LED to ensure that especially the ostium is well expanded. With wires, and once after flip-flopping the wires, the struts was open with the O by 12 mm balloon. And this is important because then it allows it to easily pass through from the left main stem into the LED. So that was the stent in the LED that was positioned. It was positioned just proximal to the lesion at the septal branch. And this was from the spider view. So remember, the balloon at the side branch, just in case, don't put a balloon in the side branch. If you deploy the stent, you might have difficulty getting a balloon. So for TAP, you should have a balloon in the side branch when you deploy this. So this was deployed at 14 atmospheres. The 375 balloon was in the. We then pulled back after deployment. I pulled back the balloon and went very. This is well described by Lavara as using the same pressure. And subsequently, this was kissed with 3.75. So the 3.5 was the stent balloon. In this case, I did not do it, and that was the results after. This is an pullback from the LED, and what you tend to see, the proximal LED, and you can see the secure. And this is what you tend to see for TAP, that for a short distance, there will be a double stent like a D, that is ED, which meets the other stent from the circumflex. So circumflex. So that's what it looks like. So another view of the still image. So you see that this is left main stem confluent circumflex, and also pull back from the circumflex. This is the circumflex and LED, and you'll be able to see that the ostium is of LED is well expanded at 9 mm squared, and circumflex at 9.5 mm, and the body of left main at 16 mm squared. So this was done about 2 years ago. Patient is still doing very well. I think, and this is the final angiographic. So really with the two-stent strategy, you need to have preparation that I think is very important. One tends to remember to remind that before any branch rewiring, because if you don't do that, and when you want to rewire something, the wire goes outside the stent struts and you may not realize it. So you need to, before you wire, remember to have high pressure inflation, especially ostium. That is very important. Otherwise, the risk of restenosis at the ostium is going to be higher. And remember, if you use a two-stent strategy, you need to have a final casing inflation. That's really debatable with the syntax study that just came out. But felt that with the two-stent strategy, final casing inflation is very important. In with regards specifically in terms of summary, I think single stent strategy, at least especially from the European guidelines, gives better result strategy. But once again, this has been defined by Dr. Chan Xiaoliang. It has to complex bifurcation, and the ostium of the side branch is Marley's disease at all. But in any case, if you want to have a two-stent strategy, what is important is actually not to have a geographical miss. That's very important. You miss ostium, and risk of restenosis there is much higher. If you use stent strategy, you just need to know and be familiar with the different techniques. And decay crush, I feel data, majority of my patients with two-stent strategy requires a decay crush. Offhand, sometimes I do a tap or pull-out technique. As to the TAP, if the TAP is fairly simple, straightforward, it's much less than a decay crush, obviously. But remember the steps. Always remember this. Remember the port after the first stent deployment. Remember that you have to have a second branch, or at least in the first vessel, by the second stent. Always remember to have high pressure inflation, especially also sometimes you may have to use, quite often you may have to use a non-compliant balloon to ensure that you get stent expansion, especially the ostium. Remember to kiss. And if you intend to do a final pot, you have got to be very careful because you have to make sure that your balloon does not extend where the stent is, because otherwise you will crush that stent. So if you have, in this case, left main or proximal vessel that you stent, the lesion segment is fairly long, well and good, you can go ahead and stent and do a final pot. If it's fairly short and you're concerned about it, you just ensure that the first pot was good. In case you have, you cover at the point of confluence. And for PCR, remember to image, and this is very important because outcome dependent on the left main stem, rather how well the stent is expanded. Left main, image them. Finally, just to refer to you, the 15 women from European Bifurcation Club. I just want to ask, we need to remember what, to understand what is a proper proximal optimization technique. Remember, for the first year, is if your balloon extends too much, then obviously perfect balloon position, and you can actually jail the side branch or the second stent. On the right most side, this is still imperfect. It's still a bit too more proximal. So what you need to do is and I would suggest that if you have a balloon, the distal marker should point where it's the mid of the side branch. And when you do that, it's quite, you'll get a nice position of your balloon. So I'd like to say thank you very much from me, from CVSKL. Congratulations again for your meeting and Independence Day today.
Okay. Thank you very much, for a very enlightening lecture on this two-stage strategy. Obviously, TAP is a very simple procedure to go ahead with. And you for the panelist expert, and now we are moving over to Fuwai Hospital, and Dr. Yang Ji An, who is the operator there, waiting for us. Over to China. Welcome. Welcome to Park Live 2020. So here I am Professor Zubair Akram. I am the moderator for the Seduce You. You are the professor and faculty of medicine, Peking Union Medical College, director for National Center for Cardiovascular Diseases, and you have been active high-risk chip procedure for the over last 20 years, and you have been performing more than 3 high-risk coronary interventions. Main interest is in TAVR operations and coronary laser atherectomies. You have been involved in more trials and published over 120 peer-reviewed articles. Let me introduce the panel of experts we are having and it's Dr. Rosley from Malaysia. He is with us. Dr. Afsar Raza here with us from UK, and from here in Pakistan we have got Dr. Bashir, Dr. Nadeem Rizvi, who is the president PSIC, and then Dr. Sohail Nadir Khan and the other distinguished panelists. So over to you, and please.
Okay, thank you very much for your introduction. Happy, so our team, all the teams are very, very happy in this weekend join the Pakistan Live for the 20 and 21. So several years ago, with my team in Pakistan, so it's already today, and although it's the big problem with the COVID-19, we can't go to Pakistan, but we are very to join this very important event, Pakistan Live. So today, and I and my team and will present as the TAVR plus the PCI, because nice population. So and among the patients who receive the TAVR, more than the 15% that the patient have the coronary problem. So and then also we when this the hybrid processor. So today, George, and he's also very famous in China in PCI, and had taken some the Pakistan several years ago. And another professor, the Professor Zhang Hongliang, he saw Pakistan before, and other the for the PCI and also for Peva, and to join us. So they are cities in China. So maybe the first of all, and the Professor Zhang Hongliang will briefly introduce.
Okay.
Good afternoon.
Good afternoon.
Good afternoon.
Good afternoon.
I'm Hongliang Zhang from Royal Hospital. Would you please?
The slide, please. No. So next,
please. This is a 68 years old gentleman. About 30 years ago, developed exertional chest pain. He was referred CEG and showed left main and left circumflex and right coronary artery, also severe stenosis. So he was referred to cabbage. About 5 years ago, this patient developed exertional chest pain and exertional dyspnea again. Then he had CEG again. The CEG showed the bypass graft is severe stenostic, but the patient refused to do interventional or surgery therapy. Then he was given more power second interventional therapy for the coronary heart disease. His exertional capacity, exercise capacity was gradually slowed down. About 1 month ago, he did echo in local hospital, which showed that the aortic valve is severely stenosis. A valve replacement was recommended. So this patient come to our hospital. Now his heart functional class is New York Heart Association 3 class. This patient is late obesity. The BMI is 31.7. A routine test showed a normal liver, kidney, and a normal nutrition status. The N-terminal pro-BNP.
No, not in detail. Just the STS.
Okay.
Briefly.
The STS is 8.6.
High risk.
Yeah.
High risk
8.6 is high risk for several. Next. The UCG showed that the mean gradient across aortic valve is 56 millimeters mercury. The peak velocity is 4.5 meters per second. The ejection fraction is preserved, is 60%. And left ventricle endodiastolic diameter is 50. The ECG a few days ago showed that left main and circumflex and the right coronary artery are also very severely stenotic. Also, we can see the calcified valve and coronary artery. Next. For the bypass graft, we can see the bypass for the right coronary artery and for LAD also occluded. The SVG for marginal branch is patent. Next. And let's see the CT imaging for the aortic root. The annulus is about 22 multiplied 31 millimeters. The perimeter is 83.5. The LVO is 21.4 multiplied about 30 millimeters. The sinus, 3 sinus is big enough. The sinus tubular junction is about 34 multiplied 36. The ascending aorta is 40 plus 40. Also, the orifice of the left and right coronary is more than 10 millimeters. It's okay. Then the left
ventricle, we can see it's not it's not very small. Also, the left ventricle wall about a little thickened. Next. For the curve angle, we can see the annulus angle is about 55. It's a little horizontal. Also, boost the centered, and the right and left sinus degree is suitable for the TIVR process. Next. For the root assessment, we can see there are calcified plaque on both and iliac artery, but it's not very healthy, and the diameter is enough. So we prefer the root femoral TIVR for this patient. Also, we can see a little curve in the descending. Next. For the multiplane CT scan measurement, we can see this patient has 3.
Okay, so let me let me say. So I think we can for the introduction. So because in the last we try to develop the different measurement for the valve. So we developed multiplane measurement. So we analyze the from level up to the STG. We try to find where is the ankle area and where area. So this is our aim. So from this the clear measurement. So I think the best anchoring is from 6 millimeter to up to the 8 millimeter. So we will implant processes a little bit higher than the normal procession. Okay, next. Okay, so this is the summary. So I think because the 1 hour ago, so we are informed. So our procession was deleted by the half hour. So we have to finish a part of so maybe I can. So because this the patient is aortic stenosis and also the coronary heart disease. Our strategy is the one-stop TIVR plus the PCI. And here also would like to introduce our Dr. Ovik and from the Bangladesh. So he's very friendly, and he has taken many to China. Yeah. So here I think he's highly appreciated. Yeah. And so maybe before the discussion this case, I just briefly introduced the TIVR program in China. So actually, so we started because the Fuwai and the Zhongshan Hospital is the first hospitals to start the TIVR. So we started the TIVR technique from 8 years ago, and up to now, so in China, and we it's more than 400 the hospitals already started the TIVR treatment, and more than 20 or 30 hospitals every year is the more so the total volume of TIVR procession, 50 cases. So now we try to develop more the devices. In China, we have several kind of device for the TIVR. So the first device, the venous S4, we have present the procession, TIVR procession with the, and after that, now we have the second device is VitaFlow, and the third one is the Tonus One. So they're already get from the China FDA. And so now is another several different designed the processes that are being on the trial. So I see here just to briefly to report the work that happening in China. So now, and I would like to ask all the panelists and to discuss this case.
Panelists like to have some comments on this case. This is a case of high-risk surgery and previous cabbage and now undergoing this CI of left main and then the TAVR.
Professor Wu, this is excellent
Yeah,
case.
thank you.
Yeah, thank you very much
for your invitation.
doing this case. We really appreciate it. Excellent case. The aortic valve stenosis and Bifurcation bypass, definitely sending him for redo surgery, the risk is going to be very high. It's the right thing to do, the TAVR, and he try to do the PCI before doing the TAVR to make life a little bit, do it afterwards too if needed, but it will be easier when you go there first, do the PCI, go ahead and do the TAVR. Now the valve you mentioned, this toric, it's probably going to be same as core valve. It's retrievable, similar to probably that. So I think that should be fine. I've already done the sizing and everything, so that should be great.
Okay, so this Rosalie, I just add on. Number one is that yes, we also do 1 or 2 patients simultaneous PCI with TAVR. When it's complex, I tend to do the coronary artery disease, in this case the left main, and then bring that back the patient for TAVR. I think it's probably because otherwise you're in too much of a rush